move on to acute kidney injury. In acute kidney injury, we have three basic forms of injury: pre-renal azotemia, intrinsic renal failure, and post-renal azotemia. Azotemia itself, as of its name, means azo means nitrogen and emia means in the blood. So basically, you have nitrogen in the blood. So what exactly is elevated? The blood urea nitrogen is elevated, and the creatinine. So blood urea nitrogen and creatinine are both elevated, and these are normally filtered by the kidneys and excreted in the urine. But if the kidneys can't filter it properly, they basically accumulate in the blood. And an important distinction is azotemia is not uremia. Azotemia is basically a lab finding. It's an increased blood urea nitrogen finding and a creatinine increase. But uremia is basically a clinical syndrome due to azotemia. So you can have azotemia without symptoms. Uremia is basically when you have symptoms like nausea, confusion, or pericarditis. Types of azotemia. So first of all, you have the pre-renal kind of an azotemia. This is when the problem is basically a decreased blood flow to the kidneys. So whenever there's a decreased blood flow to the kidneys, you have pre-renal azotemia. The causes include dehydration, heart failure, and hemorrhage. Okay, so basically, the blood urea nitrogen creatinine ratio is more than 20:1. See, here we see the blood urea nitrogen creatinine ratio. It's more than 20:1. Now, whenever we talk about pre-renal, we have certain conditions that predispose us to pre-renal problems. So before the renal problems, it can either be a cardiac dysfunction like a myocardial infarction, congestive heart failure, or vasodilation due to sepsis, cirrhosis, anaphylaxis, or hypovolemia due to hemorrhage or diuresis, or vascular resistance due to surgery or anesthesia. Surgery, lol. Anyways, so etiology includes a hypovolemia due to reduced cardiac output or a decreased effective circulating volume. Example, heart failure or liver failure, right? So pathophysiology is basically a decreased renal blood flow, and that leads to a decreased GFR, which basically leads to an increased reabsorption of sodium, water, and urea. And this basically leads to an increased blood urea nitrogen. Urine osmolality is more than 500 milliosmoles per kg. Urine sodium is less than 20 milliequivalent per liter, and FeNa is less than 1%. Remember that the fractional excretion of sodium is always 1% in pre-renal azotemia, and this is how we know that something has pre-renal azotemia, when the fractional excretion of sodium is less than 1%. We now move on to the intrinsic renal failure. In intrinsic renal failure, you have tubules and interstitium. The tubules and interstitium are basically affected and cause acute tubular necrosis. This has 4 examples: ischemia, sepsis, infections, and nephrotoxins. Now, in intrinsic renal failure, the main problem is kidney tissue damage. Kidney tissue damage causes acute tubular necrosis, glomerulonephritis, interstitial nephritis, and the mechanism is basically the patchy necrosis leads to debris obstructing the tubules and fluid backflow. So basically, it's poor filtration due to tubular damage. The tubular damage decreases the GFR because there's debris that's obstructing the tubules. There's some fluid backflow, and the GFR decreases. So in acute tubular necrosis, you get epithelial and granular casts, right? The blood urea nitrogen versus the creatinine. The blood urea nitrogen versus the creatinine ratio is about 10:15 ratio 1, and the FeNa here is more than 2%. This is a very big clinical marker here. It helps us see if something is pre-renal azotemia or intrinsic renal failure. Whenever we have intrinsic renal failure or intrinsic renal azotemia, we find that the blood urea nitrogen or creatinine ratio is 10:1. Now, whenever we have an intrinsic problem with the kidney, what are the causes that may cause the intrinsic renal failure? We have glomerulonephritis, a vascular problem where we might get vasculitis, renal artery stenosis, renal vein thrombosis, a tubular problem where there's a drug or toxin-induced ischemia, an interstitial problem where there's infection, drug-induced problem, or interstitial nephritis, right? So all these things cause the patchy necrosis, the debris obstructing the tubules, and a fluid backflow. In decreased GFR in acute urinary necrosis, you get epithelial and granular casts also. We now move on to post-renal azotemia. Post-renal azotemia will either be intrarenal, where you may have a stone obstructing in nephrolithiasis or papillary necrosis, or you may have extrarenal problems such as urolithiasis or prostatic hypertrophy. Now, in post-renal azotemia, we usually get an obstruction, and the obstruction is usually due to stones or prostate enlargement or tumors. This creates a back pressure. There's a back pressure because of the outflow obstruction, and the urine osmolality is less than 350. You have a varied answer for how much the urine sodium will be, or how much the urine, your fractional excretion of sodium will be, or the serum BUN slash creatinine ratio will be also, it varies. Acute interstitial nephritis is also known as tubulointerstitial nephritis. Acute interstitial renal inflammation is part of this. Basically, tubulointerstitial nephritis in its name tells you where the disease is. It's in the kidney tubules, interstitial space between the tubules, not the glomerulus, not the blood vessels. So the filtration barrier is fine, but the support tissue is inflamed. So in acute interstitial renal inflammation, you have a sudden days to weeks problem, and this leads to inflammation. Basically, the immune cells are attacking the kidney, and this inflammation squeezes the tubules, impairing the function and causing acute kidney injury. You get pyuria. Pyuria is classically eosinophils. And what is pyuria? It's basically pus cells or WBCs in the urine. Why do you get eosinophils? Eosinophils is always present when there's an allergy or hypersensitive cells. And their presence strongly suggests that there's a drug reaction happening. Whenever you get urine eosinophils, you think about acute interstitial nephritis. Now, the Hansel stain helps detect these eosinophils. We move on to why we get azotemia. We get azotemia because there's an increased blood urea nitrogen and creatinine. This means the kidneys are failing to clear the nitrogen waste. This is caused by the inflamed tubules and decreased reabsorption, which basically also means a decreased GFR. Since the tubules are inflamed, the reabsorption decreases and the GFR also decreases. This occurs after administration of drugs that act as haptens. So this is a core mechanism that we must know. What is a hapten? A hapten is a small drug molecule. So a hapten is a small drug molecule that is not immunogenic alone, and it binds to proteins in kidney tissue. And the immune system now thinks that the kidney is foreign because the hapten has bound it to the proteins in the kidney tissue. So basically, you get a type 4 delayed hypersensitivity reaction. So all the drugs that act as haptens, that's when you can induce acute interstitial nephritis. These are basically diuretics, NSAIDs, penicillin derivatives, proton pump inhibitors, rifampin, quinolones, and sulfonamides. What happens is you basically induce hypersensitivity. This is a type 4 delayed hypersensitivity reaction. It's T cell mediated and it's not antibody mediated. It occurs days to weeks after the drug exposure. That's why stopping the drug actually helps. Drugs that cause acute interstitial nephritis, you can, if you want to learn this, you can revise that there are 5 P's. So you P, diuretics, pain-free, NSAIDs, penicillins, and cephalosporins, that's also with P, penicillins. Then proton pump inhibitors, rifampin, that also has a P, and then sulfa drugs. So 5 P's and then an S. 5 P's and then an S. That helps you remind yourself. Now these drugs basically bind to kidney proteins like the sulfa drug especially, and then you get an immune attack. So less commonly this may be secondary to other processes. For example, in mycoplasma, you can get an immune cross reaction, or an autoimmune disease where there's Sjogren's syndrome, SLE, or sarcoidosis, you can have a cross reaction here also. The immune system also, this immune system already is hyperactive because of these systemic infection or autoimmune diseases, and basically you get kidney collateral damage because of the cross reaction. It's associated with fever, rash, hematuria, pyuria, costovertebral angle tenderness, and but can be asymptomatic as well. So you get fever, rash, eosinophilia. So just a revision here, in acute tubular necrosis, you get muddy brown casts. In acute interstitial nephritis, you get eosinophils, fever, and rash. In glomerular nephritis, you get RBC casts. In prerenal problems, you get low urine sodium, less than 1%.